Hello, everyone. Welcome and thank you for joining us this afternoon. This is a webinar, How Do We Balance Human Lives versus Economic Revival in the Age of COVID-19? My name is Vivian Ho. I'm a health economist here at the Center for Health and Biosciences at Rice University's Baker Institute. And we'll have Dr. Kantarjian speaking with us in just a moment. Let me tell you about a couple of other events that are coming up, sponsored by the Center for Health and Biosciences. On Thursday, May 28th, we will have an update on vaccine development with Dr. Peter Heltes, who's a fellow in disease and poverty at the CHB. He's also Dean of the School of Tropical Medicine at Baylor College of Medicine. He will be joined by Rekha Lakshmanan, who's the Director of Public Policy at the Immunization Partnership here in Houston. And also on Thursday, June 11th, Dr. Keonta Moore, who's a fellow here in the Baker Institute, will be talking about telemedicine and COVID-19. Dr. Moore has both a JD and an MD, so she'll be able to tell you about the medical aspects of telemedicine as well as the legal aspects. Without further ado, we are delighted to have with us Dr. Hagop Kantarjian, who's a non-resident fellow in health policy here at the Baker Institute. You may also know him as the chair of Department of Leukemia at the MD Anderson Cancer Center. And he has written some, I've had the delight to be able to work with him. He's written several pieces for us here at the Baker Institute on health policy and healthcare reform, and has published in medical journals on this topic. And you'll see by his material today that he's well versed in this area. As Dr. Kantarjian is talking, feel free to hover over use your mouse to hover over the bottom of your screen, and you'll see a Q&A box that will appear, and you can pose questions in that box, and we will get to those after Dr. Kantarjian has given us his presentation. With that, I'll hand it over to Dr. Kantarjian.
Thank you, Dr. Ho. So what I'm going to try to do is discuss our lives in the times of COVID-19, and I want to particularly address the issue of how to balance our social precautions to save as many lives as we can while preserving the economy. Do you have the slides or do I share them? So first, I'd like to acknowledge the contributions of Drs. George Barrow and James Diamond. They are two outstanding economists from Rice Baker Institute who have helped me along with the discussions regarding the economic aspects of this presentation. So I view the COVID-19 issue in terms of a moral dilemma as well as an economic dilemma. And I'm going to try to describe this in the subsequent slides. But it is fair to say that COVID-19 today has morphed from an acute pandemic, as we have seen it in Spain, Italy, or in epicenters like New York, into more of an endemic that's moving slowly, waxing and waning, and threatening the lives of individuals when it expands into particular regions. So as of yesterday, there are 5 million people infected worldwide and 1/3 people who have died. And in the US, the number of infections is 1.6 million, and the number of deaths is 92,000. Now remember, the early predictive models suggested there'll be a total of 60,000 deaths. This has been recently revised to consider probably a total of 120,000 deaths. My prediction, and it may be wrong, is that probably the number of deaths in the United States with the social and restrictive measures will be close to 200,000 by the end of this year. And I hope I'm wrong. So what you see is that, in fact, the mortality rate is 6%, but this relates to the fact that we're not testing everybody. So if you think that 80% or 4 out of 5 people who are infected have no symptoms, it is possible that the number of not clinically infected but exposed people may be 10 times higher. So maybe in the United States, as of today, 1 to 5% of the populations are infected, and the mortality therefore will be lower. So I really don't think the mortality will end up to be at 5%. I think it will be more at the rate of 0.5 to 1%. And this figure will be very important in relation to the cost of lives and to the economic turndowns. This shows as of a week ago the infection rates in the Houston area. And I'm putting it because at the end, I'm going to make some recommendations as to how low the number of new cases has to be. This is very variable. Some people say we accept a number of new cases in the range of 200, 300. I would feel more comfortable if the number of new cases with extensive testing, not like we're doing today, falls to close to below 100 for 7 to 14 consecutive days. So one of the questions is, well, how long are we going to live with COVID-19 like this? So we know, for example, that the Spanish flu lasted for 3 years and came in 3 waves. Are we going to face the same? We know that the Spanish flu infected 500,000 people, so a third of the population, the world population then, and it killed about 500 million. It killed 50 million. So really the mortality worldwide from the Spanish flu was 3%, and the mortality of compared to the world population was 3%. I do not think that this is what's going to happen with COVID-19. We have much more modern times. We're going to have the vaccines, viral drugs. And so I think it's going to be a much less of a serious threat than what happened. But how long are we going to live with this? We are going to live with the COVID until one of the conditions are fulfilled. The first one is if we discover effective vaccines. And unlike other people, I'm very optimistic, and I think that President Trump will be correct in that sense, that we will have vaccines before the end of the year. But this is a personal predictions. I think that this would be the case because of the amount of human ingenuity, the infrastructures, and the amount of money that is being spent on this. So right now, there are in excess of 100 vaccines under development. 7 of them are in clinical trials. So I expect there will be safe and effective vaccines before the end of the year. Now, if we do not develop the vaccines, for example, people mention with AIDS, we've never been able to develop a vaccine. And for that matter, we do not have a vaccine for hepatitis C. Then we will have effective viral drugs. And the example is remdesivir, which has been approved in a record time of 2 months. I think there's going to be many other viral drugs that will be developed soon. Now, if we do not develop the vaccines or the viral drugs, what we are hoping is a herd immunity exposure. So we think that the virus will be suppressed once 60% of the population in a particular environment are exposed. So for example, we know now that in Sweden and New York, the exposure rate is up to 25%. So herd immunity will happen probably naturally before the end of the year in these 2 populations. Now, the other possibility, and I'm hoping that these black swans are not rare events. I think these are realistic. So it is possible that the exposure rate is much higher than the 1 to 5% that everybody is estimating. But to know that, we have to do much wider testing of populations that are asymptomatic. Also, it is possible, like with the influenza and other viruses, that later waves will happen with a weaker COVID, which is mutated. And we've seen this happen repeatedly with most of the viral infections. The one exception was the second wave of the Spanish flu. The other possibility is that warm and humid weather will suppress COVID-19. And I think these are probably realistic things. Even though many experts predict a second wave soon, I think it is likely that with some form of herd immunity and the warm weather and with the precautionary measures that we may see either a weakened second wave or it may come in a much lesser form. Now, in the discussion, I'm going to try to use objective measures because right now, a lot of the discussions are politicized and they are emotional. And certainly when we're talking about the lives saved, the discussion becomes quite emotional. So I'm going to refer to the value of a statistical life because it's more objective rather than discuss saving a life, which implies heroic measures, or lives lost, which implies an accidental or unavoidable death. And of course, in our discussions, we increase the tone somewhat. We discuss sacrificing lives unnecessarily or sacrificing the economy. I think this doesn't help in the discussions because rather than convincing people, we can inflame and antagonize people. And I must say that none of us have the right answers. We're all learning as COVID evolves. So we're always making predictions, which are the best estimates that we can. So here's the big question that many people are asking. How does a society balance the need for social restrictions and precautions in an effort to save as many lives as possible while protecting our civil liberties and also while protecting the economies? So unfortunately, the conversations are framed by two emotional slogans at the opposite end of the conversation. The first one, and this is the opinion of many physicians, every life is priceless. And this is probably the opinion of people who are on the high end of the economic scale, people who are wealthy, who are protected, and they feel that protecting every life is important because life is priceless. But these are the people who may be the least affected by the economic consequences. At the opposite of the end of the spectrum is quoting Patrick Henry, who's the founding father of the United States, who famously stated, "Give me liberty or give me death." And I think we're hearing some echoes of this kind of a sentiment along the geopolitical spectrum. And here I'm going to emphasize why words matter and why personalizing the situation could lead us to certain biases. So for example, people say, if we lose a child, a 3-year-old child, that is much more precious than losing somebody who's 80 years old, because a child has 60 or 80 years to live more. But on the other hand, one could argue that an 80-year-old person who has lived in the United States, perhaps fought in the Vietnam War or in the Second World War, and that person has struggled in society, created a family with 100 descendants, is as valuable as the life of a child lost. Let's take the example of a mother who has to work to get a paycheck, or who rallies for the liberty and is infected and spreads the virus. If she spreads it to her child who dies, is that very different from if she spreads it to a stranger who dies? Of course, the child life would be priceless. The life of a stranger would be somewhat sad, but more to the indifferent side. So it's important then not to look at the same events through different tragic lenses, but to try to objectivize the value of a life saved or lost. And this is why we refer to a statistical life. This is the same, for example, for when we say, well, if somebody who's poor dies, is it the same value as if, for example, Bill Gates dies, or if a senator or the president of the United States dies? Then the parallel question is the GDP of nations. So we know that the GDP per capita in the United States is 65,000. So we are much more willing to pay to save lives than a nation where the GDP per capita is $10,000 or less. And finally, anecdotes of an accidental life lost in Afghanistan that we pay for about $5,000, while Libya paid $8 million for every life lost in the terrorist attack at Lockerbie. So these are different circumstances that highlight how this conversation can become very emotional depending on the circumstances which are posed. So to avoid this and to objectivize the question, we're going to use the value of a statistical life, which has been proposed by government agencies. It eliminates the emotions or the personal opinions related to age, wealth, relation to the individual, the risk according to the job, and it makes it more of a societal consideration because it assigns an equal value to a life in a particular geography, and in our case, the United States. So the value of a life in the United States is about 7 to 10 million, and this means, to state it simply, that to prevent one death in a million American, every one of these million is willing to pay $10. So a total of $10 million for a value of a statistical life. Now, this does not apply to other geographies where the GDP per capita is lower. For example, the value of a statistical life is about $4 million in Australia, only $72,000 in Russia, and $500,000 in Turkey. So now you're starting to see that as precise as we want to be in our calculations to balance the saving lives versus saving the economies, there's going to be a bias introduced that depends on how much we value these different parameters. Now, for physicians, they have a unique vision of the value of life because the Hippocratic Oath mandates that physicians must protect patients from harm and injustice at any cost. And we have in our medical lexicon the first do no harm as a dogma. But I'm going to argue that perhaps the first do no harm is a bit of a misnomer because every time we treat patients, we are introducing a potential risk, which could be minimal, like an allergic reaction to an antibiotic, or very high, for example, when we proposed a stem cell transplant to cure a leukemia, where the mortality could be 10 to 30%. So even though everybody is educated to first do no harm, I'd like to change this to first do no net harm or relative harm, which will be more accurate. And this is why even physicians, when they look at tragic events, have to introduce the concept of relativity. So encoded into the DNA of the physicians is the sanctity of life. And the immediate reflex is to say that life is priceless. We would like to save every life. So when we ask physicians about their opinion about COVID, they do not distinguish the choice between two relative events. Because historically and throughout our careers, we do not have to make such choices except when we are in situations like wars, mass shooting, natural disasters, or recently in the case of COVID in New York or Italy, where physicians had to choose which patient gets on a respirator. And thankfully, this was a rarity. But there was the example, for example, of the physician during Hurricane Harvey who was evacuating a hospital, and there were 8 desperate patients on the ventilators, and she had, and the electricity was running out, so she had to allegedly euthanize those 8 patients to alleviate unnecessary suffering, and that caused a big moral and discussion and ethical discussion. The point I'm trying to make is even when physicians argue for saving every life, in certain times they have to consider relative events and instances, even through the lens of the physician. So the ethos of the Hippocratic Oath drives, during the discussion of COVID-19, the vast majority of medical experts to favor recommendations that minimize mortality, knowing that those measures are the same ones that will maximize the economic losses. So when we talk about lockdowns, economic lockdowns, social distancing, avoiding going to restaurants or traveling or going to do movies, all of these are going to depress the economy, hoping to save a certain amount of lives. Now, the economists have a dual view of COVID-19. They evaluate two potentially conflicting mandates. They would like to save as many lives as possible. On the other hand, they would like to save the economies. Now, what is their view? Why is it important to save the economies? What they do is consider the long-term consequences of destroying economies, which may lead to a cascade of unpredictable consequences. For example, in poorer countries, economic destruction can lead to hopelessness and despair, suicides, extreme poverty, famine, as well as poor health, social unrest, upheavals, mass rebellions and revolutions, armed conflicts, breakdown of civil societies, and crimes. So, in certain estimates, these are unexpected consequences that could result in more deaths over the next decade than the number of lives saved by COVID-19 early intervention. And I'm stating this because I understand the potential, for example, in a large and poor country like India or in a continent like Africa, where economic shutdowns could have vast, unseen economic consequences if there is breakdown of the society. Now, I'm going to next focus on the value of a statistical life and make estimations that relate only to the United States. But to be able to do so, we have to agree on certain estimates. So I'm going to say that herd immunity will trigger when 60% of the population is exposed. Some people say it could trigger at 40%. Others say it could trigger at 80 to 90%. We're going to assume 60%. I'm going to assume that the mortality with restrictive measures will go down to a range of 0.5 to 1%. So I will use 0.75% in the later estimates. And I'm going to assume that today the exposure rate is 10% if we test everybody. And by the end of 2020, the exposure rate could be as little as 20 or as high as 40%, depending on how much the restrictive social measures are going to be. So these are the three parameters that I'm going to use when I calculate the value of a statistical life. Now, people have heard about the Swedish model. So Sweden and Britain decided early on, based on their medical expertise, to allow the viral spread to happen in order to accelerate herd immunity. Britain revised the course very quickly because there were a lot of casualties. Sweden modified the approach. They said we're going to protect the vulnerable and the older people, but we're going to allow all the others to gather and socialize as long as there'll be less than 50 people socializing. And the notion was among the younger people, the mortality is going to be very low, in the range of 0.2%. People who are over the age of 70 will have a COVID mortality of about 3 to 10 and maybe up to 15%. But what people don't realize is, for example, with the Spanish flu, in addition to the 50 million people who died, there were 20 million people who developed Parkinsonism. So is it possible that there are risks from COVID-19 among children or adults exposed that will happen and become part of their lives? And this is not calculated in terms of the financial losses. And also, Sweden is a country that has a lot of acceptance of the society rather than the individual. The Americans are more individualistic. And we have to notice that 50% of the households are single persons. They trust the government, and therefore they have practiced social distancing. And they notice that actually mobility is reduced by 75% in Stockholm, even though they continue to have the social gatherings and others. So what's the rationale of the Swedish model? Death is inevitable, it's only delayed. So preventive measures that flatten the curve will not reduce the total number of deaths. It will spread it over a period of 2 years or until the 60% herd immunity happens. But the current mortality from COVID-19 in Sweden is 2 to 10 times higher than other Nordic countries. And it's mostly among migrants who constitute 25% of the Swedes. And these are usually people who are poor with housing densities, so children exposing their grandparents in the same household. But what they anticipate is that herd immunity, at least some medical experts say that herd immunity in Sweden is going to happen within the next 2 to 3 months. So they would have saved the economy at some level of sacrifice of the lives, because they do not believe that vaccines or drugs are going to be available anytime soon. So the logic of the Swedish model is the total number of deaths in the long run is going to be the same with or without preventive measures, and therefore the damage to the economy does not save lives. But I would argue that this argument or model may not be valid, because if we develop vaccines or drugs before the end of the year, or if COVID is suppressed by August with the warmer weather and comes back in milder forms, then many of the deaths in Sweden would have been avoided. And conversely, by having good restrictive measures in the United States, the number of lives lost, which is anticipated to be 1 million, 1.3 million without any measures, those numbers of lives saved will be in the hundreds of thousands. Now, the Swedish model is going to be the natural scenarios in several geographies. I think it's happening in Brazil. It probably will happen in Africa because they do not have the capacity of social restrictions. But luckily in Africa, it's a younger population with the warm weather. So I'm hoping that black swans will happen in Africa, where we will not see what has happened in Europe or in New York or in some epicenters in the United States. Now, we also have to worry about unexpected consequences of disasters. So, for example, what will happen after COVID-19 in certain countries? So we know, for example, that the Russian defeat in the Russo-Japanese War, together with the 1917 cholera, has been claimed to have caused the Bolshevik Revolution in 1917. The Black Deaths, which went from 550 to 750 Anno Domini, preceded the downfall of the Byzantine Roman Empire. I think we're starting to see some of those consequences even today with COVID-19. So mercifully, and this is a positive black swan, mercifully, the COVID-19 pandemic with the lower oil prices have led to quieting the conflict in Yemen and Syria, which were proxy wars for Iran, Saudi Arabia, Russia, Turkey, and the United States. There's no money because there's no oil revenues, and therefore these countries decided to have ceasefires. And this has saved many lives, perhaps in Yemen as well as in Syria. So this is a positive silver lining to the COVID-19. But we really do not know what will happen if COVID-19 with low prices continue. What will happen to Russia or countries that depend on oil, such as Saudi Arabia? What will happen to China or India with the widespread of COVID-19? Will there be social unrest, mass upheavals, military wars, or dictatorships? People are starting to worry about the situation in Brazil. Will there be famines and deaths, collapse of societies? These are really unforeseen consequences of the COVID-19. And I do not think anybody can pretend to have a crystal ball to predict what will happen in each of these geographies. And most of the worries center around Russia, India, the whole African continent, and the Middle East. I think there'll be a lot of geopolitical changes as a consequence of the COVID-19. So let's start now applying the assumptions. So now I'm going to go back to the United States and make the calculations based on the assumptions. So we said we need an exposure rate of 60%. We're going to assume a mortality of 0.75%. With 330 million Americans, there'll be 200 million exposed, times 0.75%. 1.5 million people may die in the United States without any precautionary measures. Now, we would like to reduce the number to 200,000 or less. We're already at about 95,000 deaths. I think this is an underestimate. Probably the number is 25% higher. So I think realistically, the best we can do by the end of the year is reduce the number of total deaths in the United States to 200,000 with reasonable precautions. So if we reduce the number of deaths from 1.5 million to 200,000 with restrictive measures, we're saving 1.3 million lives. Multiplied by 10 million, that's $13 trillion. But you could say, wait a minute, you just told us that COVID may subside by December, either because we'll discover vaccines or drugs, or maybe the second wave will never happen. So to compare apples to apples, I'm going to use an exposure rate of 20 to 40%, not 60%. So this means that 66 to 130 million Americans will be exposed, and therefore reasonable restrictive measures will save 500,000 to 1 million lives, which will be now worth not 13 trillion, but only 5 to 10 trillion. So this is where you start seeing diversions of opinions, because the calculations can vary differently depending on the estimates you're making. Now, COVID will have definite economic consequences. We know that 36 million people are unemployed now. The jobless rate has hit 15%. It may go up to 20 to 25%. And the reality is COVID-19 has exposed the economic and healthcare disparities in the United States. So when you look at Wall Street, you assume the economy is doing very well because the stock market is still doing incredibly quite well. But Main Street is the one that is affected. So in fact, when you see people like me talking about protection and so on, the people in the upper range of the economy are the people who are the least affected by COVID-19. It's mostly the people in the middle and poorer class who are bearing the major consequences of economic 19. People who live from paycheck to paycheck, people who are now without any health insurance. The uninsured has increased from 30 to 50 million. The Congressional Budget Office assumed a decline in the GDP in the second quarter of 12%. So if you annualize this, you multiply it by 4, that's about 40%. But many people think this is an exaggeration because we think that the third and fourth quarters are going to show very strong signs of recovery. But the unemployment rate may persist at a higher rate because we have some economies which are completely devastated, like the service economies. So there's going to be continued job losses. And one conservative estimate assumes that we're losing $7 trillion per year. So I showed you the previous figures of saving the lives that will be valued at $5 to $13 trillion. And here I'm showing you that the economists are saying that we're losing $7 trillion because of the economic depression. So from the conversation, you already noticed that what I started with as the value of a life index time of COVID-19, a moral and economic dilemma, we tried to objectivize it, but we cannot because now it's politicized. There are some elements who say, well, you just told us that we can save only 5 trillion. So I'd rather relax the restrictions to be able to go to work. And these are people actually who are in the middle and lower class. These are the people who are struggling and they would like the economy to open up. Now, as a person who is a healthcare worker, I would say, and this is controversial, I would say there is a good life, a good value to continue optimal preventive measures. They do not have to be necessarily lockdowns. I would like to see much more COVID testing, contact tracing and isolation to avoid mini centers. And anytime there's one that happens, we have to increase the social restrictions. And for my level of comfort, I would like to see in a large population, say 1 million or more in a particular area, I would like to see the number of new infections with wide testing to go below 100 on a daily basis for 7 to 14 days. But this is where there are differences in opinion depending on our individual and political convictions. Some people are comfortable with the number of new cases being in the range of 200 to 300. I would say that for Houston, the reopening is a reasonable one, but we must have much more COVID testing. We must have the infrastructure to contact, trace, and isolate people. And personally, I would like to see less than 100 new cases a day for several consecutive days to relax the measure much more. I'm going to put a note here that even subtle variations in the estimates of what I said. So I said the exposure rate today is 10%. By the end of the year, it could be as low as 20 or as high as 40%. I said that the mortality rates could be 0.5% or 1%. Some people say it may be lower than this. I do not think it's going to be lower than 0.5%. But such estimation, such subtle variations in the estimations can sway the argument for more restrictive or more relaxed measures, depending on the individual level of comfort and the economic and political convictions. And we're already starting to see this happening in different states in the United States, as well as in different countries, for example, Brazil versus Europe, depending on the geopolitical inclinations of their leadership. I hope I have not confused you more than helped you with this discussion, and I'm happy to answer any questions.
Okay, thank you, Dr. Kantarjian. And we're now going to move to questions. This is a clarification question about where did you get the number of 60% infected for herd immunity?
So this is an estimated expert opinion. Some people say for COVID-19, depending on the R node, so the level of exposure. So for example, with influenza, every person infected can infect 1.3 other individuals. With COVID-19, every infected person can infect 5 to 7 individuals without precautions and 2 to 3 individuals with precautions. With this kind of infectivity, people assume that herd immunity will happen at 60%, which means that those 60 out of 100 will serve as buffers for the others. Now, there are some experts who say the herd immunity will continue until 80. The herd immunity will trigger only when we go up to 80 to 100%. But if you think of the influenza epidemic, the herd immunity triggered at 35%. Over 3 waves, there were only 500 million of 1.5 billion people who were infected. You could say it's because it came in 3 waves and it became attenuated and died out. But it is possible that COVID-19 will die out the same as the Spanish flu also. So 60% is an estimation. Some people will argue, well, maybe we will have like the Spanish flu where the herd immunity will trigger at 35 to 40% instead. But I think 60% is a realistic figure.
Thank you. For people who are submitting questions, please submit them under Q&A and not chat to, so that I'm not bouncing back and forth between 2 boxes down in the, on my screen. I'll take the next question. Even if there is an FDA-approved vaccine by the end of the year, how long will it take to get the majority of the US population vaccinated?
So that's a difficult question because people say you'll have to scale this up and it may take months and we cannot produce 100 million vaccine. The reality is we have enough of the human ingenuity. We have enough of infrastructures and drug companies, and the president could use certain measures to ask companies or other medical facilities to produce the vaccines on a large scale and to avoid any issues related to the cost of the vaccine by making it generic as soon as it comes onto the market.
Okay.
So I really do not, I think that's an issue that people bring up, but considering the number of lives lost, I think that the United States, with all our financial and infrastructure powers, we could expand the production of the vaccine to be able to vaccinate most Americans within 2 months from the development of the vaccine.
Okay. It would also assume that there may be a decrease in the spread of the virus during the summer months. What if that doesn't happen?
If that doesn't happen, then we will need to assume significant restrictive social distancing. We will have to do much wider COVID testing and tracing to avoid the spread. And anytime we see a mini epidemic in certain particular areas, we have to do small geographic lockdowns in those areas. This would be, in my view, the worst case scenario. I'm very encouraged by the fact that there are whole countries that have been so far spared the complications of COVID-19. So for example, I've had contacts with colleagues in Lebanon, in Iraq, in Saudi Arabia, and in Egypt, and in Israel. And they are saying that actually they are not seeing as much of a COVID-19. I do not know the reason behind this. If you think about it, it can be the age of the population, the density of the population, the use of mass transit, so how much people are on top of each other, whether they are a vivid society like Italy or New Orleans or a more reserved society like Japan. And finally, the healthcare infrastructure. I really do not know, and thankfully, I really do not know why certain countries have so far been spared. I was very concerned about Africa. Now, it's possible that they are not reporting because they are not testing and they are not reporting the cases who are dying. But I'm hoping that there are certain things which are unknown to us. For example, some genetic resistance to COVID-19 that is sparing certain societies, such as in the Middle East, perhaps in Africa, hopefully in India, but I do not know.
Okay. Another question, do you think the current way that Houston is reopening will cause higher infection in the weeks to come?
So there are two variables which are happening simultaneously, which are important. The first one is we're testing much more. So when we test much more, we're going to detect many more cases, and we're reopening. So as we see an increase in the number of new cases or a stability of those new cases without a reduction, is this related to reopening of the society, or is it related to wider testing? Now we can do some calculations. We could say, well, today we're testing, let's say 10,000 and we're detecting 200. If in 2 weeks we're testing 100,000 and we're detecting 2,000, we'll say this is related to the testing rather than related to reopening of the economy. So if we do the calculations in terms of the number of people tested versus infected, and we see the same ratio by increasing the number of testing, then we will know that the reopening is safe. If we look at that ratio and it's much higher than expected, then we will have to assume it's related to reopening of the society.
Yeah, and by the way, I would agree with your preference to see fewer than 100 cases per day for 7 to 14 days. That is lower than what is going on right now in the city. My reading, though, is that there are many people who will not go back out and shop and buy services and go to the movies until the case gets down to that level. So when we're talking about a trade-off between closing the economy and opening it, I don't think people are taking that into account, that if we open too quickly, we actually get a very anemic economic response. Okay, moving on to the next question. It's from India. It says, in India, we have seen less than 3,300 deaths. Can India justify total lockdown for a long period? It is less than 100 cases per million. Should they end lockdown?
Absolutely. So I tried to allude to this. I do not know where certain countries have been spared. It is possible that they are not reporting the deaths or they are not testing, but it is possible, and I hope that it is the case in India, that because it's a younger population, that perhaps there's much more spread of other viruses, say corona, the regular corona, not the COVID-19, that those populations have a certain immunity to COVID-19. So this has been discussed by healthcare experts. There are other coronaviruses which are circulating in the population, and people assume that exposure to those other less dangerous coronaviruses could provide some form of immunity against COVID-19. So I'm hoping and assuming that certain countries, such as India, where there's much more social contact, or in Africa, that there could be much more of the other forms of coronavirus that have given those populations some immunity. And as I said, the scenario in Sweden may become the natural scenario in poorer countries. Perhaps India cannot afford a lockdown because the economic consequences will be devastating to 1.3 million individuals, most of whom are poor. So it is possible that in India, doing severely restrictive measures when the number of deaths is so small may be more harmful in the long run than expected. I'm hoping that also poorer nations in Africa, if we combine young age with the warm weather, with the fact that we're not seeing a high reporting, that maybe restrictive measures will do more damage in the long run in terms of economic damage and in its consequences than just letting the herd immunity happen. I really do not know the answer, but I'm hoping that some countries will be spared simply because of factors that we do not know yet.
Thank you. Okay, this question is from a Rice faculty member. This is a macro analysis you've provided, and they're wondering how institutions should address this issue, and do you have any recommendations for Rice University?
I'm gonna push back that question to you, Dr. Ho. I do not know what Rice University should do. I know that the Texas Medical Center is at risk because we have many vulnerable patients, so we really cannot afford COVID-19 to spread into healthcare institutions. And these are the most vulnerable because, as you know, the patients are in the hospital, the healthcare workers are in constant contact. So I think in the medical center, we must have much broader COVID testing. We have to keep the restrictive measures. We shouldn't allow for visitors into the hospital because the more people access those facilities, the higher the risk of COVID-19. So for the medical center, I think we have to have restrictive measures which are more serious than what we're doing in Houston. For Rice University, I do not know. It's a different institution where these are young people. But again, if you have one young person who's studying at Rice who, God forbid, dies, I do not know the emotional impact and actually the emotional impact to that particular family. So I'm going to ask Dr. Ho to address that issue.
Well, David Lebron just sent out a notice yesterday, and he's formed a committee that will actually be discussing how Rice will open in the fall, and they will make a final decision in July. I will say I agree full-heartedly with your recommendation that we have more testing in the population. It's clear we have insufficient testing and we need more contact tracing. And when you think of the dollar amounts you're talking about the trillions of dollars we're losing in our economy, the additional investment that we have to spend on testing is minuscule compared to that. And I am frustrated that Congress is not, and the administration are not sending much more support to expand testing, because that's what's actually keeping our economy shut down in many ways. Okay, the next question.
I'm going to add something, and this is me thinking out loud. If I were on that RICE committee, I would say we can open, but we have to make sure that the classes have the social distancing, that hygiene is performed, that the infrastructure is as sterile as possible. So you have to clean up the classes and so on, and maybe do more virtual education. And I would say that for physical presence on the campus, we have to do the blood testing on all the students to see the ones who are IgG positive and therefore immune. And perhaps we have to request a nasal swab testing on anybody who has any symptoms, or perhaps on everybody every 2 weeks. But I'm not sure. But whatever you do, you really cannot afford any lives lost in those circumstances because of the moral as well as the legal implications.
Right. Thank you. So we only have about 10 more minutes left, and I got many, many more questions. So let me try and get through as many as I can. Don't we need a coherent federal COVID-19 policy? Although different states and businesses have different risks from COVID, all the states are interconnected.
Yes, so this is the question. If you have social restrictive measures in one state and not in another, and you have a much higher infection rate in that other state, and they come back to Texas, will they infect many more? This is what the worry about Texas versus Louisiana, for example. So I think there has to be a form of coordination. Also, states do not have the latitude of you or the finances to be able to handle things on their own. So I think it has to be a dual nationwide effort, as well as also tailoring to particular geographies. There are some geographies who are completely immune to COVID-19 at present, mostly in rural areas and others. So they could open up much easier than denser cities. So I think we have to have a broad US policy, but also look at individual geographies and allow for certain differences.
Okay, there's a question about mutation of the virus, but I'm going to hold off on that one because our May 28th webinar is going to cover that in extreme detail. I'm sure of that. So the next question, you mentioned that Houston may be okay to be opening, but what's your opinion on the influence of potentially infected travelers? Should they be managed as 14-day quarantine? Is that possible?
I do not know the answer to that. I know that we are imposing quarantine. The alternative to imposing the quarantine is everyone who accesses Houston gets a nasal COVID testing. Now, people could say the false negativity is 20%. But if you do 2 nasal COVID testings on day 1 and day 2, the false negativity rate goes 20% times 20% to less than 5%. So I would propose, instead of the 14-day quarantine, that anybody who accesses Texas from outside gets tested on day 1 and day 2, and they are quarantined. And then if they are negative, then they can do whatever they like. This is what we're doing right now for patients with acute leukemia. They want to come to MD Anderson. They cannot be quarantined for 14 days. We bring them because they could die if we don't bring them. We test them on day 1. If they are negative, we try to test on day 2. If they are negative both times, then we do the social restrictions and we treat them like normal individuals. I think with severe restrictions, particularly in healthcare facilities, we may be harming patients who are not coming to the facility and staying at home and delaying their treatment. I worry about patients with leukemia, but I've heard examples, patients with head and neck tumors, who are operated and who may have wound infections and not coming. So I think we have to start thinking of the unintended consequences, and therefore to try to open up more, but with more COVID testing, tracing, and isolation.
Okay. How long after all the reopening do you think we need to wait before we know if we moved too soon or was it okay? And which data and data sources would you zero in on? So much of it is delayed and flawed and confusing.
Correct. So I would say if you open up, and it will take about 2 to 4 weeks to see the consequences. But again, what you have to do is look at the percent of new cases compared to the number of tested. So if you're testing 100,000 and you see 1,000 cases, that's a 1%. If you test 1 million and you see 10,000 cases, then the opening has not affected it. It's just the testing. But I would say that if we look at the ratio of infected to tested, and if it's a constant over 2 to 4 weeks, then opening up Houston has been safe. If we start seeing that the percent of infected compared to the tested is higher, then we know that opening is causing more infections.
Okay. A couple of people asked something like this. What data is suggesting that the summer months will reduce the spread of COVID-19?
We don't know this, but we've seen data from different areas looking at warmer versus colder weathers and implying that the COVID spread is less in warmer and humid weathers. And it makes sense, and it's been the case for other viral infections. And now there's laboratory data that suggests, for example, that COVID-19 can live 8 hours to days on particular surfaces, but as you increase the temperature by a certain number of degrees, you reduce the infectivity at a level of 2%. So I've seen somewhere where they say that every centigrade affects the infectivity by 2%. So if you increase the temperature from 80 to 90 degrees in Houston, you can probably reduce the infectivity by 20%. So, but these are estimates. There's no hard data to do that. But I'm one of the people who believes that warmer and humid weather is going to reduce the infectivity rate. And that's why I'm hopeful that Houston and Texas, being not dense, we do not use much mass communications, and with the warmer weather, that we will have less of the effect of COVID-19 than what happened, for example, in Italy or Spain or New York.
Mm-hmm. I've also seen sources that the virus really does not do well in sunlight, in UV rays. I don't know if you've seen the same thing.
Correct.
Yeah. Okay. Just to circle back about the issue of patients. I am a patient in your department at MD Anderson. I had a routine checkup scheduled in April and it was postponed until next month. What has changed in terms of risks since then? And when should we go back to normal healthcare routine? So here's your chance to clarify.
So I think MD Anderson has implemented outstanding measures, and it's not because it's my institution, but I really think that the measures at MD Anderson, and they have been implemented at a time when we knew very little of COVID-19. And thankfully, those measures implemented by our leadership have led to very, very low levels of detection. So for example, the number of COVID-19 at MD Anderson has been in the single digits. Yesterday, there was only 1 patient. So the measures that we've implemented in terms of restrictions, distancing, hygiene, face masks, restricting visitors, closing the labs have been extremely beneficial. I cannot say enough about the vision of the leadership that led to where we are today. So I'm very happy about what's happening at MD Anderson. I think it's happening across the medical center. And we must at all costs prevent COVID from accessing the healthcare areas, because if that happens, it will be a COVID mini epicenter in a vulnerable population. So what's happening today has allowed us to say, let's open MD Anderson cautiously, stepwise, and look on a day-to-day basis at the levels of infections. I must state here that my opinions today do not represent those of my institutional affiliation or those of the Baker Institute.
Yes, and mine neither, but I will add, I was at MD Anderson yesterday as a patient for a follow-up visit. And with all the additional precautions, I really think it's the safest place in Houston other than my own home, being in your own home. Okay, so we have hit 2:30, but I just want to ask one more question. Could you talk about vaccinating the rest of the world? So this viewer thought, well, you talked about the vaccine being developed and it could go to everyone in the US in 2 to 3 months, but what about the rest of the world?
Dr. Ho, I do not know the answer to that. I think if we have a vaccine, we should spread it across the world as quickly as possible for multiple reasons. One, to save lives, but equally importantly, in poorer countries, to save economies. Now, they may perhaps not need the vaccine. As you heard from the question from India, they have not seen too many cases. I do not think it's a fluke, and I do not think it is totally because of underreporting or under-testing. I think there are certain geographies, for some reasons unknown to us, which are more protected than others from COVID-19. But if a vaccine is available, I think it should spread as quickly as possible throughout the world.
Absolutely, absolutely. Well, thank you very much, Dr. Kantarjian, and thank you for everyone for staying with us for this webinar and asking some very thoughtful questions. We appreciate your attention, and we hope to see you on one of our future webinars. Thank you again. Bye.
Stay safe.